Hi everyone, my name is Jessica and this is my professional PowerPoint on dysarthria. So what is dysarthria? Dysarthria is known as a group of speech disorders due to damage in either the central or peripheral nervous system or both. As a result, a dysarthric patient could experience muscular control weakness, slowness, or incoordination of the speech mechanism. This disorder affects all the basic processes of speech production including respiration, phonation, resonance, articulation, and prosody. The classification of the different types of dysarthria encompasses flaccid, spastic, ataxic, hypo and hyperkinetic, and mixed dysarthria. Each one of these pathologies has its own unique characteristics depending on where the site of lesion is. Unlike apraxia, dysarthria involves a weakness of muscles and incoordination, while apraxic patients have the full physical capacity to complete a task. So for assessment, during a diagnostic evaluation, it's important to distinguish key factors among the different dysarthrias as many of their characteristics overlap. To complete an assessment of dysarthria, it's important to obtain a complete oral facial examination and a good speech sample at structured levels and in continuous speech. Strength, speed, symmetry, range of movement, and steadiness of the jaw, face, and tongue, and palate is what the therapist looks for in an oral facial examination. These structures are observed at rest, during speech, and during non-speech movements. To assess overall awareness and ability to program, the therapist should ask the patient to imitate various oral movements during vocal play, including lip smacks, lip trills, tongue protrusion, cough, and blow. The therapist should also engage the patient in altering motion rate, or AMR, tasks to assess the rate, rhythm, precision, and range of motion of rapid movements of lips, jaw, and tongue. Pitch quality, loudness, duration, and steadiness can be assessed during vowel prolongation. If the patient is unable to produce a sustained tone, a breakdown is expected to be in the respiratory and laryngeal processes. Informal assessments such as reading out loud and spontaneous speech should also be taken into consideration. These speech samples will also help determine the speech rate, phrase length, voice quality, prosody, resonance, and precision of articulation. Formal tests such as the Enderby-French dysarthria assessment or the Yorkston-Buchelman and Trainer's assessment of intelligibility of dysarthric speech are useful assessment tools. Both assessments are able to establish a differential diagnosis. While the French exam also contributes to the patient's neurological diagnosis, the Yorkston-Buchelman and Trainer test assesses intelligibility at the single word and sentence level as well as the rate of the patient with dysarthria. So as we know, there are 7 types of dysarthria. Flaccid includes weakness, lack of normal muscle tone, hypernasality, imprecise consonant productions, breathiness of voice, nasal emission, and it's found in the lower motor neurons. Spastic includes muscular weakness, greater than normal muscular tone, imprecise consonants, harsh voice quality, hypernasality, strained and strangled voice quality, reduced range of motion in the upper motor neurons. Ataxic characteristics include inaccuracy of movement, slowness of movement, imprecise consonants, irregular articulatory breakdown, prolonged phonemes, prolonged intervals, and slow rate, found in the cerebral control circuit. Hypokinetic dysarthria includes rigidity, decreased range of motion, short rushes of speech, monoloudness, monopitch, dysphagia, mask-like face, and decreased breath support. Hyperkinetic involves abnormal and involuntary movements, dystonia, forced exhalation, hypernasality, short phrases, and slow rate, and dysmetric face. And unilateral upper motor neuron dysarthria includes weakness in the lower face, lips, tongue, and the opposite side of lesion, as well as some other characteristics. There's also mixed, which is a mix of symptoms mentioned above. So treatment can help with communication intelligibility. To facilitate expressive language and communication, various things can be done, including strategies for compensatory speaking or AAC devices and modifying the environment. To increase loudness and respiration, postural adjustments must be modified. Breathing strategies may also improve respiratory support for speech. Various therapy treatments such as speaking immediately on exhalation, stop phonating early, and determining optimum breath groups may also aid in increasing respiration. There are also some other ways to improve speech intelligibility and prosody so the therapist should focus on rate control. This can be done by finger or hand tapping to set the pace for syllable production, or establish cued readings in which the patient marks the pauses when reading out loud. There's also contrastive spell drills and intonation drills, and also articulation of each sound syllable may help slow rate and improve articulatory precision. Thank you.